Hi everyone. This presentation is about newborn adaptations and nursing care of the newborn. Here are your objectives for today's lesson. Please review these. These are the key terms that you'll need to know, so make sure that you familiarize yourself with them. The most significant changes, physiologic changes, that happen to a person's body in their lifetime is when they're born. The systems that are particularly affected are the respiratory and cardiac systems. So let's first talk about the respiratory system adaptations. So a baby is born, they take their first breath, their lungs, when they're in utero, are filled with fluid. So they have to go from an environment where their lungs were fluid filled to one where gas exchange occurs in the extrauterine environment. So if the fluid is not fully removed from their lungs, that can lead to a condition called transient tachypnea of the newborn. So some of those conditions that can cause the fluid to not fully be removed are having a C-section, having a precipitous delivery, which means the entire labor process happened in under 3 hours, or if the mother is under sedation, which crosses over to the newborn. So some signs and symptoms of respiratory distress in a newborn would be grunting, retractions, nasal flaring, or tachypnea. So the normal respiratory rate for a newborn is 30 to 60 breaths per minute. So if a baby is breathing above that 60 breaths per minute, that is considered tachypnea. Newborns also should have shallow, unlabored breathing. They may have short periods of apnea up to 15 seconds, okay, so that is considered normal. Chest rise should be symmetric. If they are having any issues, that would be concerning. So like I said, if they are having grunting, retractions, nasal flaring, cyanosis of the mucous membranes, those are concerning issues. Now let's talk about surfactant. So surfactant is a lipoprotein. It prevents the alveoli from collapsing. So the body naturally makes surfactant, and that surfactant production primarily occurs in the 3rd trimester. So if a baby is born prematurely, they're not going to have adequate surfactant to allow the air sacs to open and close and allow gas exchange to happen easily. So what causes the baby to take their first breath? Well, it's a combination of factors. So chemoreceptors associated with labor, changes in pressure as that baby goes from the intrauterine to extrauterine environment. They come out and they experience the cold environment, which can stimulate them to take a breath. And also other sensory stimuli, such as lights, sounds, and smells that they are then exposed to. So what happens is the baby takes their first breath, respiratory movement is initiated, the lungs expand, okay? So the fluid that's in their lungs part of it is reabsorbed, part of it they might be coughing out, so they might need suctioned right away when they're born. But if they transition without any difficulty, usually that process happens without any distress to the newborn. Functional residual capacity is established, which allows pulmonary gas exchange to start. Pulmonary blood flow is increased. So initially when the baby is in utero, there is not a lot of blood flowing to the lungs. There's enough to allow the lungs to grow, but we don't need the lungs to be functioning in utero, right? Gas exchange happens in utero via the placenta. So in utero, not a lot of blood flow to the lungs. After the baby's born, the resistance of the blood flow going to the lungs goes down, and then the baby is able to perfuse their lungs. Cardiac output is also redistributed. The other system that is predominantly affected by changes from intrauterine to extrauterine life is the cardiovascular system. So the circulation changes from fetal circulation to newborn circulation. Previously, the placenta was doing the gas exchange. Now the lungs are doing the gas exchange. There are physical forces that lead to an increased release of catecholamines, which is the release of epinephrine and norepinephrine during that labor process. And those are critical for helping the changes that occur from the transition to extrauterine life. So initially, the placenta provides oxygen and nutrients and removes waste. After the baby has been born, the lungs obviously are doing the gas exchange, and then the baby is circulating their cardiac system on their own. So what happens during labor? So the physical forces of labor are the contractions. The contractions during labor help prepare the baby for extrauterine life. So that cord is compressed, and that catecholamine release happens, and so actually going through the process of labor helps prepare the baby for transitioning, which is why the babies that are born by C-section who don't go through labor, or the babies that go through labor in that precipitous labor that happens very quickly, have a little bit more difficulty transitioning after they're born. So the baby goes through the stress of labor, and that helps them be able to clear their lung fluid, and the cardiovascular changes occur after the baby has been born and that umbilical cord is clamped. The heart rate for a newborn is between 110 and 160 beats per minute is your normal newborn heart rate range. So make sure you have that number memorized. That number usually decreases to an average of about 120 to 130 beats per minute as their baseline. But just like we do, their heart rate fluctuates with their behavioral state. So when a baby is sound asleep, its heart rate is going to be on the lower end of that range and may even fall below that 110 beats per minute. So it's not uncommon to see a newborn heart rate 90 to low 100s if the baby is sound asleep. And some babies just normally have a low resting heart rate. And also when a baby is awake and screaming, their heart rate is going to be much higher. So it might be as high as 200 when they're awake. The baby does rely on their heart rate for cardiac output and for their blood pressure. Regarding blood volume, about 85 milliliters per kilogram is what their blood volume is. It varies depending on whether or not they've had delayed umbilical cord clamping, which means when the baby is born, instead of clamping the umbilical cord right away, it is now common practice to wait between 1 to 3 minutes and to allow that baby to get extra blood from the placenta and umbilical cord. The purpose of that is the baby gets a larger extra blood volume, so it's kind of like giving that baby their first blood transfusion, helps boost their iron stores, helps stabilize their blood pressure, helps them improve their oxygen transport. It increases the red blood cell flow, and it can increase the overall blood volume by about 30% in term infants and 50% in preterm infants. Regarding blood components, the fetus has more red blood cells per cubic millimeter than the adult does, and those red blood cells are larger in size, and because they're less efficient at oxygen exchange. So when a baby is born, their red blood cell count ranges between 4.6 and 5.2, and very quickly the hemoglobin level declines. The reason for that is that most of 70% of the baby's blood contains fetal hemoglobin, which the cells have a shorter lifespan than newborn or adult hemoglobin does. So then their hemoglobin level decreases and you see a physiologic anemia of infancy. So that usually is at its lowest when that baby is about 5 weeks of age. So that hemoglobin can fall by up to 55%. So we expect to see that physiologic anemia when the baby is about a month old. Regarding white blood cells, if you were to look at a baby's white blood cell count, it will likely be high, anywhere between 9,000 and 30,000, and that is due to the trauma of birth. So if you're looking at a baby to see if they have an infection, you're not going to look just at the white blood cell count because that is not going to tell you enough of a picture of what's going on with that baby. Regarding platelet count, it is the same as an adult's platelet count, so 150,000 to 300,000 as their normal. But they do have low clotting factors because the newborn is unable to synthesize vitamin K. And I'll talk a little bit more about that later in this presentation. Regarding changes to fetal structures, I'll talk about those in the next slide. And so basically there are 3 fetal shunts that are open during while the baby is in utero, the foramen ovale, the ductus arteriosus, and the ductus venosus. So after the baby is born, those fetal shunts all close, and also the umbilical arteries. There's 2 umbilical arteries, 1 umbilical vein. Those are obviously gone after the baby is born and that cord is clamped. So looking at these 2 diagrams of the heart, the one on the left, which shows all of that purple blood, that is the fetal circulation. So take a minute to familiarize yourself with this picture. And there's the 3 fetal shunts here. So you have the ductus arteriosus up towards the top, the foramen ovale, which is between the atria, and the ductus venosus that goes to the lungs. So what happens is when the baby is born, they all start to close. Okay? So the ductus venosus allows most of the blood to bypass the liver and go to the vena cava. That closes within a few days of birth. The foramen ovale allows blood from the right atrium to cross over to the left atrium, so it bypasses pulmonary circulation. Remember, we don't need a lot of blood going to the lungs when the baby is in utero because the gas exchange is occurring through the placenta. We only need enough blood to go to the lungs to allow them to grow. And then at the top, the ductus arteriosus connects the pulmonary artery to the aorta. Again, it helps bypass pulmonary circulation, and it closes within 10 to 15 hours after birth. So that process starts to occur very quickly after birth. They begin to close, and then everything transitions to the picture on the right where you have the very clearly delineated oxygenated and deoxygenated blood. So in fetal circulation, everything is opposite of adults. So the oxygenated blood comes to the fetus through the umbilical vein, which is opposite from the adults, and the deoxygenated blood goes back to the placenta via the arteries. So on a newborn umbilical cord, there are 2 arteries and 1 vein. So remember that. When a baby is in utero, their saturations are about 40 to 70%. So as you can see from looking at that fetal heart and all of that blood is mixed, that baby is living in a hypoxic environment in utero. And that's okay because that's expected. They don't need to oxygenate their lungs, and everything is happening via the placenta. So when a baby is first born and you see them and initially they are blue, and that's okay because they came from a hypoxic environment. and that changes very, very quickly as that baby transitions. So a baby comes out, and if they're looking very, very purple, very bluish in color, and their saturations at about 1 minute of age, we would expect their saturations to be anywhere from 60 to 65%. And then by the time they're 10 minutes old, that should be between 85 and 90%. So that transition happens very, very quickly where they're able to circulate their blood flow systemically. Go ahead and watch this YouTube link here, and it's just another quick snapshot that explains those fetal shunts. Next, I'll be talking about thermoregulation of the newborn. Looking at this photograph here, what can you see that's wrong with this picture? Well, there are a few different things. So the baby in the middle on the front is not swaddled very well, and none of these babies have hats on. So you're going to be focusing on very closely some interventions to maintain thermoregulation in the newborn, and these are a couple examples here of what not to do. So the term thermoregulation means the balance between heat loss and heat production. So what we want to do as caregivers of newborns is we want to maintain a neutral thermal environment. So what we're trying to do is we're trying to provide interventions to where they are not having to use any of their energy to maintain their temperature. So we're monitoring their temperatures very, very closely on the newborn floor. So heat production for newborns occurs primarily through non-shivering thermogenesis. So what that means, first of all, newborns do not have the ability to shiver, and they don't get that ability until they're about 3 months of age. So the way that they are making heat is they have what's called brown fat. So brown fat is oxidized in response to cold exposure. So brown fat is primarily made in the 3rd trimester, and it disappears by the time a baby is 3 to 5 weeks old. When the baby is cold, norepinephrine is released, which stimulates brown fat metabolism by breaking down triglycerides. So the baby is going to burn through their brown fat if they are cold stressed. They're also going to try to make heat by increasing their heart rate. So not only are babies not able to bring up their temperature when they're cold, but they're also prone to getting overheated. So reasons for that: they have a large body surface area, they have a limited ability to sweat, and also environmental factors. So if you put them in an environment that's too warm, they're not able to tell you that, and they can get overheated very easily. So again, we're very, very closely monitoring babies' temperatures on the unit. So overheating, another reason that occurs. So heat is regulated by the hypothalamus and the central nervous system, and babies have immature central nervous systems. I want you to remember the normal newborn temperature range, which is 97.7 to 99.5 axillary. Okay, we're always going to be doing axillary temperatures on babies, and the proper way to take an axillary temperature is to make sure that the tip of the thermometer is all the way underneath the newborn's arm. You're going to hold that baby's arm down for up to 3 minutes until you get that reading on your thermometer. So why are newborns predisposed to heat loss? Well, there are several reasons. First of all, they have thin skin. Their blood vessels are close to the surface. They lack the ability to shiver. They have limited metabolic stores, so limited amounts of glucose, glycogen, and fat. And remember, glycogen is the part of glucose that is energy. They have limited voluntary muscle activity. So like we do when we're cold, and we're able to change positions by, kind of pulling themselves in, they don't have the ability to do that quite as easily. They have a large surface area compared to their body weight. They don't have a lot of subcutaneous fat, and like I had mentioned, they're not able to conserve heat by changing posture. They're not able to adjust their own clothing and blankets, and they're not able to tell us if they're too cold or too warm. So again, frequent temperature checks on the unit, and we're going to be doing a lot of interventions to make sure that those babies maintain that neutral thermal environment. There are 4 primary mechanisms of heat loss. Make sure that you are familiar with the 4 different mechanisms and can give examples of each of those. So conduction is transfer of heat from one object to another that is in direct contact. So some examples would be a cold surface. So if you put a baby on a cold surface and they get cold, if you touch a baby with cold hands, or have a cold stethoscope that you're putting on a baby. So some interventions we would want to do: make sure you rub your hands together and warm them up a little bit before you examine a newborn. If you're going to be weighing a baby, you're going to cover the scale with a blanket first. And you are going to also offer skin to skin for the mom and the baby. So this is a way to use conduction as a way to maintain that baby's temperature. So what we would do is we would encourage mom to go chest to chest with baby. So baby's only wearing a diaper and is undressed, and we put the baby under mom's gown directly in mom's chest, and she and baby are skin to skin and maintaining temperature that way, and the baby is covered behind with a blanket. The next mechanism is convection, which is flow of heat from the body to a cooler surrounding air. So examples would be if there was a fan on, if there was a draft, air conditioner, a breeze from a window. Okay, so make sure that you're doing interventions to minimize those airflow movements. Evaporation, so that is heat loss from when a liquid is converted to a vapor. Okay, so one of the very first things we do when the baby is born is we dry them off, and then we get rid of that wet linen. So that's an example of trying to decrease heat loss from evaporation. Okay. Also, they can get cold from a bath, from being wet. So make sure after they are bathed that you're drying them off. We want to basically keep them as dry as possible, and also use warm blankets, and also put a hat on them. Radiation is heat loss from solid surfaces to near, but not in direct contact with the newborn. So, for example, when you put your hand up to a window on a cold day and you can feel that coldness coming through, but you're not actually touching it, that's what radiation is. So we want to keep babies away from cold windows, from outside walls where the coldness can come through. So one of the ways to do this is to transport the baby to the nursery in a double-walled isolette, so that prevents that radiation from the coldness of the outside environment to get to baby. Here is a visual of those 4 mechanisms of heat loss for those of you that are visual learners. And again, so that process of cold stress leads to depleted brown fat stores, also increases the baby's oxygen needs, can lead to respiratory distress. Remember, they're trying to breathe faster to bring up their temperature. Then glucose is used, okay, so that leads to hypoglycemia. Okay, so remember your interventions that we're going to do for your newborns. We're going to keep them as warm as possible. Sometimes we need to put them under a radiant warmer in the nursery. Encourage skin-to-skin contact with mom. Put them in a transport isolette when they're going from labor and delivery over to the newborn nursery. Dry them off at birth. If they need oxygen for any reason, they get heated, humidified oxygen. And the other thing that we're doing is we are delaying their bath. So back in the day, they used to bathe the baby as soon as it came over to the newborn nursery. Now we are encouraging parents to delay the bath for up to 24 hours. The reason for that is so we're not having the baby be cold stressed. Okay, so we're allowing that baby to regulate their temperature more, allowing them to regulate their heart rate more, and we're letting them use their energy to then focus on breastfeeding versus trying to keep up their temperature from being cold stressed. The other thing that they found is that vernix, which is kind of that really whitish coating that a baby has when they're first born, it's what protects their skin in utero. That vernix kind of acts as a natural moisturizer for them. So they leave that on the baby's skin as well. And then typically at 24 hours of age, the baby does receive a bath. There are a couple of situations where a newborn would not qualify for a delayed bath. So some examples would be the mother has HIV, or the mother has any kind of infection, like an infection of the uterus called chorioamnionitis. Those would be some indications where you would need to bathe that baby right away. You wouldn't delay. This is a picture of a mom and baby that are doing skin-to-skin care. So ideally, right at delivery, the baby is put skin-to-skin on mom's chest. So as you can see, this mom and baby are just gazing at each other, they are loving it, and that really helps with bonding. Okay, so there are a lot of benefits to doing skin-to-skin care. So as I mentioned, helps promote thermoregulation, helps stabilize the baby's heart rate, temperature, and their breathing. If they are breastfeeding, it allows that breastfeeding to happen sooner and is more effective. So studies have actually shown the sooner that a newborn breastfeeds, the better off the mom's milk production is going to be. So if a baby nurses in the first hour after delivery, the mom is going to produce 4 times as much colostrum as if she started in hours 2 through 6. And colostrum is that initial milk that the mom has. It's really thick, yellowish, and it's a really small amount, sometimes about a teaspoon at a time at the max. And the mom is going to make more of that if that baby does skin-to-skin right away. Studies have also shown that the mom is able to produce more long-term. So if she has done skin-to-skin and breastfed within that first hour, she is going to produce 130% more milk than if she did not breastfeed in that first hour. So again, it's called the golden hour, and skin-to-skin has been shown to be very beneficial in that time frame. Skin-to-skin also helps with reduced crying and pain. It helps that baby regulate their blood sugar level, so they're not using their own glucose to stay warm. There's also some benefits to mom as well, besides just bonding. It also helps moms release oxytocin, which helps their uterus contract. And when their uterus is contracted and stays really nice and firm, postpartum bleeding is controlled. So very, very good to do skin-to-skin and to encourage moms to do this right away. Now I'm going to talk about newborn stools and voids. And this goes into more detail in your feeding lecture. So stools on a newborn initially is meconium. So meconium stools are really thick, dark, tarry kinds of stools, and they're really hard to wipe off if you have to change a diaper of a meconium stool. So meconium is made out of amniotic fluid, shed mucosal cells, intestinal secretions, and blood. So all of that is normal. It lasts about the first 24 hours, and then that stool starts to transition. So you get the transitional stool, and then it becomes the milk stool. For breastfed babies, their stools are yellowish gold, loose, stringy, has been described as seedy, so it might look like they have tiny little like sesame seeds in it. And it's a little bit sour smelling, but not foul smelling. There's a wide range of what's normal as far as amount of stool for newborns. So some breastfed babies will have a stool with every diaper change, and some don't stool for 2 or 3 days. So there's a wide range of what's normal. For formula-fed babies, their stool is yellowish to yellowish green, loose, pasty, or formed, and can have an unpleasant odor. So basically, breast milk is tailor-made for the baby, so there's less waste to it. So that's why the baby might not have quite as large of amount of stools when they're breastfed. A formula-fed baby, there's more waste, and they also tend to overeat more as well. So that's why they might have larger stools or more frequent stools. As far as voids, so they should have 6 to 8 wet diapers a day. Now that'll be when they are a week of age. Initially, they're not going to have that many wet diapers. So what we would want them to have is in the first 24 hours of age, we want them to have 1 wet diaper. In the second 24 hours, we want them to have two wet diapers, and so on as the minimum, until they get to that week of age when we want them to have 6 to 8 wet diapers. So babies do have immature kidneys and a decreased ability to concentrate urine. So they may have, that's why they have that 6 to 8 wet diapers a day. Also initially too, I wanted to mention the fluid loss. So in the first week of life, they can lose 5 to 10% of their birth weight. That is due to fluid shifts, insensible water loss, and they have a decreased calorie intake. So like I had mentioned, initially a mom that is breastfeeding is getting really small amounts of colostrum. She may get about a teaspoon per feeding, and that's okay because a baby doesn't need a lot of volume of feeds initially. And that colostrum should be all that the baby needs until that mom's milk comes in about day 3 to 5. That colostrum is really rich in calories and protein, and it's very, very good for babies. The babies have a very, very small stomach capacity when they're first born, so you want to give them small, frequent feedings. So their stomach is about the size of their fist. So when you're first feeding a baby, if it is a formula-fed baby, you do not want to give them more than about 5 to 10 milliliters. If they drink too much, then they're not going to be able to keep it down and they're going to vomit it right back up. So something to consider. And then as the baby gets a little bit older, so by the time they're a couple days old, they might be able to take 1/2 ounce to 1 ounce. So their stomach kind of stretches out. But just kind of keep that in mind when you're feeding a baby. You do not want to overfeed them. So you need to know how old that baby is and when they ate last if you are bottle feeding a baby. Regarding newborn skin, there are a lot of different common skin variations. So make sure you review those. I'm just going to touch on a few of them here in this presentation. So this first picture, this baby has stork bites. So as you can see on that baby's forehead and on the eyelids, they have these little red areas. Stork bites are usually on the eyelids, between the eyes. They can be on the nape of the neck, on the back of the baby's neck. They are a normal variant. They are gone within a year or 2. The neck lesions sometimes are visible onto adulthood, but they are normal. They're nothing to be concerned about. This next picture shows milia, which are those little white dots on the baby's nose. So what those are, they're sebaceous glands, and they're just on the surface. So you can see those commonly on the baby's nose, forehead, sometimes across the bridge. The picture of the baby's backside shows Mongolian spots. So Mongolian spots are just some hyperpigmented areas. They are common in babies of darker ethnicities, and they usually disappear over months, but they can last a few years. You do want to note when you are documenting your baby's assessment, you want to record that the baby has them and the location of them. And the reason is that we want to, if the baby ever comes back into the hospital, we don't want there to be any suspicion of abuse if the baby has these spots. So make sure that you do comment about the location of their bruises, or I'm sorry, their Mongolian spots, because they do look like bruises, but they are not. The next picture shows a baby with erythema toxicum. So that baby has, it's called neonatal acne sometimes. It may also be called a flea bite rash. It's common on the face, the chest, and the back, and it's usually gone within the first few days, but it can last up to 3 weeks. And again, there's no need to do any interventions for it. It clears up on its own, and you can reassure the parents that there's nothing to be concerned about. For the reproductive system for newborns, the females may have an enlarged labia. The labia majora covers the labia minora. The clitoris is usually enlarged, and that is due to the influence of estrogen and progesterone that they've gotten from their mother. They also might have what's called pseudomenstruation. So they may have a little bit of bloody tinged discharge in their diaper. And again, that is from the hormones from mom. It is transient, it goes away within a few days, and it's nothing to be concerned about. So if you do see a little bit of like bloody discharge in a baby girl's diaper, just be reassured that that is a normal finding. For your baby boys, they are going to have foreskin that covers their gland. They're going to have a midline urinary meatus, so make sure you're looking for that and making sure that it's midline. Their scrotum is going to have rugae to it, so that wrinkled appearance to their scrotum. Their testes should be descended, so you're actually going to palpate the newborn boy's scrotum and make sure that you can feel both testes that are down in the scrotum. There should be no bulging, which would be an inguinal hernia, and it's normal not to have hydrocele, so fluid in the scrotum. Fluid in the scrotum is common, and it usually does reabsorb with no issue, but if you do see that, make sure you document that. Both newborn males and females may have swollen breast tissue, and again, that's from that reflection of the hormones from mom. A newborn's neuromuscular system develops from cephalocaudal, meaning from head to tail, and from proximal to distal, so from the center outwards. So as far as babies' senses, they have very acute senses of hearing, smell, and taste. So for hearing, they can respond to a sound. If you want to check that your newborn that you're assessing can hear, you can make a loud noise in front of them, like clapping. You can, for taste, they can distinguish between sweet and sour by the time they're 3 days old. For smell, they can smell their mom's breast milk. And for vision, they do not have a very good sense of vision, but they can see best about 8 to 10 inches in front of their face. So when their mother is holding them, they can look and they can focus on their mother. They see best in they see shadows more than they do solid outlines, and they see shades of black, white, and gray more than they do for colors. Adaptations to respiratory, circulatory, thermoregulation, and musculoskeletal systems indirectly indicate that the central nervous system is working effectively. So as we had talked about, respiratory, normal lung function depends on them having surfactant. They go from that fluid-filled environment to the air-filled lungs. And those babies that have a C-section, they don't go through the squeeze of the birth canal. So that might be one of the reasons that they may have more fluid in their lungs and more of a wet sounding sound to them when you're listening to them, and why they also might have a little bit of respiratory distress. As far as respirations, they're shallow and irregular. The normal rate for respirations is 30 to 60 breaths per minute. Make sure you know that range. When you are listening to a newborn's respiratory rate, you're going to count it for a full minute. Since they are irregular breathers, they might have periodic breathing, which is they can have pauses in their breathing, normally between 5 to 10 seconds, even up to 20 seconds. And that can be normal, so that you want to count for that full minute and make sure they're in that 30 to 60 range. As far as reflexes, go ahead and watch this video that's attached. Some of the reflexes that are normal newborn reflexes that you see on assessment. You've got the Moro reflex, which is also known as the startle reflex, the Babinski reflex, which is when you stroke their foot and their toes fan out. They have a palmar grasp, so if you put a finger or something in their hand, it'll grasp that. They also have a plantar grasp, so if you put your finger at the base of their toes, they'll curl their toes around that. There are a couple other ones that the video mentions. Some that are good for breastfeeding are sucking and rooting. And as you can see, newborns also have swimming as a innate reflex as well. Enjoy that video. The newborn's head can have a lot of variations. The first I want to mention is molding. So molding is when the newborn's suture lines overlap each other and they have kind of that elongated shape to their head. And that is really just so the baby's head can form to where it can come out of the birth canal. So molding is normal, and it does resolve so that baby's head straightens out to like a normal rounded shape, usually within a couple days after birth. So go ahead and look for a picture of molding in your textbook. Then there's these images here. So the first picture where it says A, that is a picture of caput succedaneum. So what that is soft tissue swelling that crosses the suture line. That can occur from prolonged labor or from use of a vacuum during delivery. It usually resolves within 3 days. So when you're feeling that newborn's head, you're just going to feel like some swelling, some edema to that baby's head, and it's usually benign, and like I said, it resolves spontaneously within about 3 days or less. The next picture, picture B, is showing a cephalohematoma. So as you can see in that picture, that baby has a hemorrhage on one side of the scalp. So that usually happens, again, from a traumatic birth with use of a forceps or vacuum. That mass is firm. It does not cross suture lines. It resolves in about 2 to 8 weeks. Hemolysis can occur. So if you think that baby has a collection of blood under the surface, and as those blood cells break down, it can lead to jaundice in the baby. So a baby with a cephalohematoma is at an increased risk of jaundice. As you can see, the difference between picture A and picture B is that the caput succedaneum can cross the suture line, so it can go all the way across the scalp like a cap. Okay, remember that. And the cephalohematoma, again, it's blood, but it is confined by the periosteum and it does not cross the suture line, so it is on one side of the head. It's unilateral. The third picture, picture C, is a picture of a subgaleal hemorrhage. So this is a rare occurrence. It is an emergency occurrence. but I wanted you to be aware of this because they have seen it up on the newborn in the newborn nursery, and it has gotten missed on an assessment, and the baby luckily had a good outcome, but there is now a protocol in place that any baby that has a delivery where they had to use forceps and vacuum, they're doing extra checks called a subgaleal hemorrhage protocol to make sure that that baby doesn't have a subgaleal hemorrhage that is getting missed. So on the subgaleal hemorrhage, that again is caused from shearing forces such as use of the vacuum, but in this case, the bleeding has occurred into a deeper space. It's happened in the subgaleal space. So that baby can lose a large amount of its circulating blood volume into that subgaleal space. If that baby has a severe subgaleal hemorrhage, their head is going to feel like you can just feel the liquid moving underneath the surface. It feels kind of like a waterbed, if any of you guys know what a waterbed feels like. They can have hypovolemic shock. It can lead to DIC, so disseminated intravascular coagulation, or death even if it can be very, very severe. So on the unit for the subgaleal protocol, they are frequently checking the baby's blood pressure, their pulse, their head circumference, their capillary refill, and their hematocrit levels for the first 24 hours. You would have to check out the protocol to see the timing of those. I believe they're about every 4 hours that they're having these checks done. But again, they're looking for signs of hypovolemic shock. So they're looking for that blood pressure to be low, that pulse to be high, the head circumference, if it is increasing in size, is a concern, and the cap refill, they want that to be less than 3 seconds. The way that you check capillary refill on a newborn is to push down on the infant's chest for 3 seconds, release your finger, and then that blood return should come back within 3 seconds or less. For the skeletal system, the newborn spine should be straight. It flexes easily. They can lift their head briefly, and they can turn their head from side to side when they're prone. When you're looking at the newborn spine, what you're going to do is you're going to have the baby laying prone, and you're going to take a finger on each side of the spine, and you're going to run your finger all the way down the baby's spine, and you're going to make sure that it feels nice and straight. They sometimes have a sacral dimple, so right at the sacrum there might be a little dimple or a little cleft. That can be associated with spina bifida. So if a baby does have something that looks like that, like a little dimple or a cleft in their sacral area, make sure you look at it very, very closely. You want to make sure that you can see the base of the skin to make sure that that area is closed. Otherwise, it's concerning for spina bifida, and they will be getting an ultrasound of that area. If they have kind of looks like a dimple or a pit, and you cannot see the base of that, that baby will need follow-up on that. On the baby's extremities, they are symmetric. They should have symmetric movement of their extremities. So notice that when you're doing your assessment, so they're moving their arms and their legs equally. They also have nails that are present on their extremities, and then also, of course, count that your baby has 10 fingers and 10 toes. The picture that this is showing is they're showing a baby that has developmental dysplasia of the hip. So what that means is that one of the baby's hips is not correctly in the socket. So some ways to test for this is you're going to look at the baby's gluteal skin folds. So looking at the baby, especially you can tell when you're looking at the picture of the baby's buttocks, the skin folds are not equal from side to side. Okay, so that would be a concern that the baby has developmental dysplasia of the hip. You're also going to check what's called Ortolani and Barlow maneuvers. Ortolani means you are bringing, you're going to put 2 fingers on the baby's greater trochanter. You're going to pull the baby's legs out, kind of abduct them, and that's called an Ortolani maneuver. As you're bringing the baby's hips back in, you're going to feel, if you can feel like a click or a clunk. That could indicate that that baby's acetabulum is sliding back into socket as you're bringing that leg back to midline. So that would be something to follow up on for sure as well. And babies that truly have a developmental dysplasia of the hip will need to go home in a special harness that stabilizes their hips. It's called a Pavlik harness, and they'll have to wear that for a few months, and they'll have to follow up with an orthopedic pediatric physician. Now I'll talk about behavioral characteristics of the newborn. So initially, the baby has a period of reactivity, which the baby is very alert. They're moving, they might appear hungry. So when the baby is first born, they're usually very alert. They initially cry when they come out, but they're alert enough to where you ideally want to have them go skin to skin with their mom, not only for bonding, but to start with breastfeeding, because they're going to be alert and awake and vigorous and be able to feed successfully, ideally. After they have that really alert period, they go into a period of decreased responsiveness that starts anywhere from 60 minutes to 100 minutes of age. So in that period, they are very hard to stimulate and to arouse, and it's difficult to interact with the baby at that point. So if you have not fed the baby in that initial first period of reactivity, and then they get to that period of decreased responsiveness, they might really struggle and not be able to feed, and then that could lead to problems with their blood sugar, and it can just kind of be a downward spiral from there. After they have that really sleepy period, they have a second period of reactivity that starts between 2 to 8 hours after birth. At this point, the baby wakes up, shows an interest in stimuli. This is a really good time to answer any questions that the parents might have and to do some teaching with them, and again, to promote some more feeding. Look at the chart of the sleep-wake states in your textbook on page 545. So babies transition from several different sleep-wake states, from deep sleep all the way to crying and everything in between. I want you to remember that the best time to do an assessment on a newborn is in the quiet alert state. So if you're trying to do an exam on a newborn and you're trying to test the different newborn reflexes, if your baby is in a deep sleep, or if your baby is very irritable and crying, they may not do those reflexes for you. And again, it's also going to be more difficult for you to do your baby's vital signs if your baby's crying. So ideally, doing your assessment in the quiet alert state is going to be best. Moving on to chapter 24, nursing care of the newborn. A lot of this information overlaps with the previous chapter, but kind of talks about how to manage it. So some of the information from these slides may overlap from chapter 23 to chapter 24 as you're reading through the chapters. So when you're taking care of an infant, one of the things that you want to know, even before you're dealing with the infant directly, is you want to know the maternal history. Look at box 24.1 on page 550 in your textbook, because it very clearly outlines conditions and concerns of the mother that you need to know. So we want to know if the mom has any pre-existing conditions, genetic factors. We want to know her blood type and RH, whether she's gotten prenatal care, any medications that she's on, any history of STIs, her labor history, and her group beta strep status. So group beta strep, or GBS, is a condition that it's a bacteria that is in the environment and is a normal flora. If a mom is positive for GBS, she is usually asymptomatic. She may have a UTI, but she is not usually too badly affected. However, if she does not get treated with antibiotics and then she transfers the GBS to the baby can get very seriously ill with sepsis or pneumonia. So we want to know the mom's GBS status and whether or not she received IV antibiotics while she was in labor. The next thing we want to know is the baby's APGAR scores. So what APGAR is, I'll get to that a little bit more on your next slide, but it's going to tell you how well that baby is transitioning from intrauterine to extrauterine life. We want to know the baby's vital signs. So again, make sure you remember your ranges, your heart rate, 110 to 160, your temperature of 97.7 to 99.5 axillary, and your baby's respiratory rate of 30 to 60 breaths per minute. Blood pressure is not routinely done on a healthy newborn, so you do not need to know values for that. When you're doing a baby's heart rate, you're going to listen for an apical pulse. You're going to listen for a full minute. And note that murmurs can be common. A lot of times, especially in that first 24 hours, you may hear a murmur as those fetal shunts are beginning to close. So you may hear a murmur one time and then go back an hour later on that same baby, and that murmur may be gone as that shunt has closed more or closed completely. As far as vital signs, length and weight, the normal length for a newborn is 45 to 55 centimeters, which is 17.7 to 21.7 inches. And a normal weight for a newborn is 2,500 to 4,000 grams, which is 5.5 pounds to 8.8 pounds. So make sure you know the pounds and the grams and the centimeters and inches. As far as physical maturity, I will talk about that in the next couple of slides, and we'll get to that. The APGAR scoring system is a way to tell how well that baby is transitioning from the intrauterine environment to the extrauterine environment. So looking at 5 different characteristics, the baby gets between 0 and 2 points, giving the total up to 10 points. So the indicators, as you can see, are activity, which is muscle tone, their pulse, their grimace, so their response to reflexes, appearance, which is the skin color, and respiratory effort. So this scale was developed by a physician named Dr. Virginia Apgar in the 1950s, and somebody just made it nicely go along with her name for each of the indicators. So if your baby has a score of 8 or better, usually no interventions are needed. The baby is scored at 1 minute of age and then again at 5 minutes of age. So when the baby is born, there is a timer on the warmer in the delivery room. The baby's born, somebody shouts delivery, they hit the timer to start the timer. After 1 minute, that timer dings, it goes doo-doo-doo-doo, and that's when the provider knows to get the APGAR score. It does it again at 5 minutes, and so you'll have 2 different scores. What you will want to know about the APGAR score is that you are not going to ever see a baby get a 10 for an APGAR score. Usually they're going to lose at least 1 point for color, because as you can see, 2 points for appearance for skin color is pink, meaning that they are pink, their body and their extremities. If you remember, that baby came from a hypoxic environment in utero, so they are not going to be fully pink. You would not expect to see them pink. So it's kind of considered a bad omen to give a baby a 10 on their APGAR score. So if they're going to lose points, these indicators kind of disappear in a predictable manner. So the baby's first going to lose points for color, then respiratory rate, then tone, then reflexes, and finally heart rate. So heart rate might be considered the most important indicator on the APGAR score because it's going to be the last one to go if your baby is really, really in distress. This tool shown here is called the Ballard Gestational Age Assessment. So what this tool does is it looks at different characteristics of physical maturity and neuromuscular maturity. So physical maturity being the skin texture, the amount of lanugo or that fine downy hair that a baby has, the plantar creases on a baby's foot, how much breast tissue they have developed, how developed their eyes and ears are, and then also how developed their genitals are. The neuromuscular signs are looking for different characteristics that a baby will be able to do based on their gestational age. So I don't need you to know specifics about this tool, but I just want you to know that there is a tool out here. Your book talks a lot about it, so I wanted to touch on it. And this tool is used primarily if you have a baby who you don't know the gestational age of this baby. Maybe the mom didn't have any prenatal care, or maybe that they're thinking that the dates that the mom gave do not match up with what that baby looks like developmentally. So I was a nurse in the neonatal ICU for 8 years, and I have seen a lot of babies have this Ballard done, especially when their mom did not get prenatal care. There was one example I can think of where a newborn was born in the toilet and called EMT, and the mom said that she had a miscarriage and that everything was in the bathroom, and they went in there and they found a baby floating on a placenta in a toilet. So I did take care of that baby. That baby did end up being okay, and on the Ballard, that baby actually ended up being about 28 to 29 weeks gestation. So definitely viable, and it ended up doing okay in the end, going home with a foster family. But just know that this tool does exist and can help you determine how old that baby is as far as their gestational age. And the reason that's important to know is because we might have different expectations and different plans of care based on how old that baby is. Okay, going with gestational age and birth weight. So AGA stands for appropriate for gestational age. So that is your babies that are between the 10th percentile and the 90th percentile based on their gestation. So full-term baby, if they're born on their due date, is 40 weeks, okay? So what we're looking at is we're looking at a growth chart, and we're looking at babies that are 40 weeks, and we're plotting out their weight and that they're falling in between those percentiles based on their age of being 40 weeks of age. A baby who is born at 28 weeks, for example, we would take their weight and plot them out for a 28-week-old baby and see if they are AGA based on their gestation. So that's another reason why we need to know that baby's gestational age, to see if they have grown as we have expected them to grow in utero. LGA stands for large for gestational age. So that's those babies that are above the 90th percentile for their weight. So those are going to be your babies that are over 4,000 grams for a term baby. And SGA then would be babies that are less than the 10th percentile. So they're going to be less than 2,500 grams for their for their weight when they are full-term gestation. Okay. Then you've got preterm or premature. So these terms get a little bit confusing and a little bit fuzzy, but just know in general, a preterm baby is going to be considered a baby that's born before 37 weeks gestation. A baby that is late preterm, they further break that down. So late preterm is a baby born between 34 weeks and 36 weeks and 6 days. Okay. Early term is considered term, but still in the early part of it. So 37 weeks to 38 weeks and 6 days. Full term is considered between 39 weeks to 40 weeks and 6 days according to your textbook. But like I had said, any baby that's over 37 weeks is considered a full-term baby, but still you may have some differences between those babies born in 37, 38 week range and those babies born in the 39, 40 week range, especially in regards to their respiratory status and how developed their lungs are. They may also have some more feeding issues if they're born in the 37, 38 week range, and especially the babies born before 37 weeks. Late term is considered 41 weeks to 41 weeks and 6 days, and post-term is after 42 weeks. Typically, you are not going to see babies that are post-term because there are risks associated with having a baby born post-term. That placenta starts to calcify, starts to break down and not perfuse as adequately, and your baby can be larger, which makes a more difficult delivery. So a lot of your physicians are going to be inducing your moms before they get to that term. So you're not going to see babies that are 42 weeks and beyond in general. So some complications can occur depending on if the baby is SGA, LGA, or intrauterine growth restricted. So I'll talk about those. So SGA, so your small for gestational age babies. So obviously they're more at risk for having issues with hypothermia. Also would be more at risk for having issues with hypoglycemia, having more issues with oxygenation, and they may have more issues with feeding. Your babies that are LGA are typically going to be your babies that are infants of diabetic mothers. So what has happened is these babies have gotten all of this glucose that has crossed the placenta and gone to baby, which has caused them to grow larger. So insulin does not cross the placenta like glucose does. So the baby has to make its own insulin in response to getting all of this extra glucose from mom. Once the baby is born, that glucose source is immediately cut off. But the baby is not able to stop making insulin that quickly. So then they bottom out their blood sugar by making too much insulin. Okay, they don't have that glucose source anymore, but they can't stop making insulin as quickly as that glucose source is shut off. Okay, so that baby is called, that baby has hyperinsulinemia. Okay, so not every LGA baby is a baby of a diabetic mother and has hyperinsulinemia, but it's something to consider because a lot of those babies are. So again, those LGA babies, they're at risk for hypoglycemia. They're also at risk for birth injuries, okay? So those babies may have been more likely to have had a delivery where they had to use vacuum or forceps, so it can cause some trauma there. Those babies are also at risk for having a clavicle fracture as a result from a traumatic birth. They are also at risk for, if they've had a traumatic birth, having more bruising, which then bruising leads to jaundice, and they may have more issues with jaundice. Another complication is intrauterine growth restriction. So looking at this picture, this shows a healthy full-term newborn compared to a baby who has been growth restricted. As you can see, the growth restricted baby has a large head proportionally for its body size. So babies that are IUGR or intrauterine growth restricted, they may be born at full term and just not anywhere near that growth curve. So or they may be born preterm. So some reasons that they might be growth restricted: infections from mom, drug and alcohol use, hypertension from mom, so everything is constricted and blood flow to that placenta is very poor, or a poor diet from the mom. So all babies that are IUGR are small for gestational age, but not all babies that are SGA necessarily have IUGR. So what are some nursing interventions that we want to do in the immediate newborn period? Obviously, the first thing we want to do is airway, right? Always airway first. So maintaining a patent airway. For a newborn, that's going to be using that bulb suction. So it's that little blue bulb. And if the baby needs suction right away at delivery, they are going to suction the mouth before the nose. So if you ever need to suction a baby, always remember mouth before nose, M before N, just like the alphabet. And clear that baby's airway out. When you're in the delivery room, you're always going to put a proper identification band on the baby. Okay, so their baby's going to have a band with all the information that matches mom's name band and also dad or whoever is the designated care partner. So name bands are put on the baby right away. A sensor is put on the baby's umbilical cord clamp, so that baby cannot go too close to an elevator up on the unit, or you're going to cause a security alarm to go off. You also want to take your measures to maintain thermoregulation on your newborn, so dry that baby off right away, put a hat on the baby, put the baby skin to skin with mom. Make sure you're taking all the proper steps to make sure that baby doesn't get cold and use its energy to have to maintain its temperature. We're going to promote parent-infant interaction. So, like I said, get that baby skin to skin with mom. That is your ideal scenario. Get that baby breastfeeding, early breastfeeding. That baby will get antibodies from the breast milk, and will also, breastfeeding also helps with bonding, and always encourage mom and baby to stay together as long as baby is healthy. So if there is something that's gone wrong, the baby is in respiratory distress, or the baby is too cold, so if the baby has a temperature below 97, they would have to take the baby to the nursery right away and put the baby under a warmer. But ideally, we can keep babies warm enough, we can keep moms and babies together as much as possible is our goal. Babies will routinely get 3 different medications at delivery. The first is eye prophylaxis with erythromycin ointment, and that prevents eye infections from a mom who has gonorrhea. Now, erythromycin is given prophylactically to every infant, even if the mom is not known to have gonorrhea, because it can be so severe that the infant can go blind. If a mom has gonorrhea and doesn't know it, and we've not given the eye prophylaxis, the results can be detrimental. So since erythromycin is readily available and it's a fairly inexpensive drug, we do give it to every newborn prophylactically. The next is phytonadione or vitamin K. That is given as an IM injection. So you can see that little picture down below shows what the pre-drawn up syringe of vitamin K looks like. Newborns need vitamin K because they do not produce it in adequate amounts initially in that newborn period. So babies need bacteria in their intestine to be able to make vitamin K. Since the baby hasn't eaten yet, the newborn bowel is sterile, so it hasn't produced any vitamin K until that baby starts feeding. So there are not adequate levels of vitamin K until the baby is about a week to 2 weeks of age. So very, very important that the baby gets vitamin K injection. Parents can refuse the medication, but it requires a lot of education to the parents And we really highly encourage babies to get vitamin K so they don't have bleeding issues in that newborn period. And especially if you have a baby boy who's going to be getting a circumcision, if they have not gotten their vitamin K, they can really hemorrhage during that procedure. And then finally is a hepatitis B vaccine, which is a standard vaccine that is due initially in the newborn period. Sometimes parents do refuse that first hepatitis B vaccine and they delay it until the baby's 2-month appointment, but it is really encouraged to get it in that immediate newborn period for protection for baby. So some signs of potential complications if they have an abnormal respiratory rate, so anywhere outside of that 30 to 60 breaths per minute range, if they have any abnormal breath sounds, crackles, wheezes, grunting, nasal flaring, retractions, stridor, those are all abnormal. Cyanosis, so now for a baby, we're going to look for cyanosis on their oral mucous membranes. Remember, they might have some cyanosis on their extremities, some acrocyanosis, as they're trying to regulate their systemic perfusion. So if they have some kind of bluish color to their hands and feet, it's totally normal in the first 24 to 48 hours. So you are not going to look at their hands and feet for cyanosis. You're going to look centrally on their mucous membranes. If you have any concerns about a baby's respiratory status, put a pulse ox on them, and you want that baby's pulse ox to be above 95%. If it's below, you may need to be doing some interventions, including giving oxygen. And you do want to put the pulse ox on the baby's right hand because that is considered a pre-ductal reading, and that's where you're going to get the highest saturation in the baby's body. A common respiratory problem in the newborn period is transient tachypnea of the newborn. So what that means is that is mild respiratory distress. Baby can have tachypnea. It is usually benign and it usually resolves within 24 to 48 hours. What this is from is the inability for the baby to absorb fetal lung fluid. So as I had previously mentioned, the babies that are going to have their fluid in their lungs are going to be the babies who have had C-sections, who have not gone through the squeeze of the birth canal, or who have not had that catecholamine release during labor. So your baby's born precipitous labors, or if the mom has gotten some anesthesia or medications that have affected the baby to where they're sedated, that those babies might have not as strong of a respiratory drive and may have more trouble clearing out the fluid in their lungs. So if a baby has transient tachypnea, they may need oxygen. You'll need to keep them warm. You're going to observe their respiratory status frequently, and they just need time for those pulmonary capillaries and those lymphatics to remove the remaining fluid. So time is really just going to be what the baby needs to resolve this issue. So these babies will be on a continuous monitor in the newborn nursery for at least 12 hours once they are off of oxygen. Okay, so on your physical exam, you're going to start with vital signs. I have mentioned all of the normal ranges for your vitals already, so I'm not going to mention those again, but just know that you're always going to do an axillary temperature. Heart rate is going to be apical. You're going to listen for a full minute. Respiratory rate, you're going to listen for a full minute. And it is best to listen to your respiratory rate on the right side of the baby's chest, just so you're not hearing heart sounds interfering with your respiratory rate count. Blood pressure, we only need to do it for a baby that's on that subgaleal protocol, or if they are a level 2 baby, which means they need to stay in the nursery on a monitor. So your normal newborn nursery babies do not need a blood pressure. Okay, so then just doing your physical exam, going from head to toe. So you're going to look at the face, you're going to notice symmetry, you're going to look at the nose. It should be small, narrow, midline, patent nares, so you're going to occlude one nostril at a time and make sure that the baby can breathe without difficulty and should have an intact septum. The mouth should be pink and moist. You're going to assess the palate. You're going to place a gloved finger in the baby's mouth, and you're going to feel the palate and make sure it's smooth and dome-shaped and doesn't have a cleft. You're going to assess the palate for Epstein pearls, which are little white epidermal cysts on the gum and hard palate. So sometimes they have those little cysts, and sometimes they even have a natal tooth, which is just a calcium deposit. It isn't an actual functioning tooth, and usually they just leave those in place unless it interferes with baby's feeding. I have never actually in person seen a natal tooth, so they are very rare. As far as the eyes, they might have some edema. They might have some subconjunctival hemorrhages in their sclera from the stress of labor and delivery. They may have strabismus, which is wandering eyes, and nystagmus is also common in the first 3 to 6 months. Their ears are soft and pliable. They should recoil when you fold them over. They should snap back into place, and they should be aligned with the outer canthus of the eye. So if you draw an imaginary line from the outside of the eye over to the ear, it should be in line with about the top third of the ear being above that imaginary line. So look at their ears, make sure that they are symmetric and that they are in line. You're also going to look for the ears to make sure that they're fully formed. You're going to look for any skin tags in front of the ear or preauricular sinuses or pits. They can have those as well. So make note of those if they have anything abnormal. And also to mention, babies are going to have a hearing screen during that initial newborn period. So every baby will have a hearing screen before they are discharged. Their neck is short. It should move freely. They should be able to hold their head briefly without support. When you're looking at a baby's neck, you're going to make sure that they don't have an extra thick nuchal fold. So if you see like a thick fold on the back of the baby's neck, that can be an indicator of Down syndrome. And that is actually something that they can notice on a prenatal ultrasound that is a marker for them to screen further for Down syndrome. The baby's chest should be 2 to 3 centimeters smaller than the baby's head. As I had mentioned, the baby's nipples may be engorged due to maternal estrogen. And on the chest, you're going to auscultate lungs for symmetry, so you're going to listen upper and lower lobes on both sides. On your heart rate, you're going to listen for your S1 and S2. Murmurs are common, especially initially when those shunts are closing. The one that you can hear the most is the foramen ovale. The heart rate is very, very fast. It's hard to count, so you might not know that you're hearing that S1 and S2, and you may have a really hard time trying to keep in tune with getting that heart rate. So a couple of tips to help you focus on that heart rate. Close your eyes. That'll kind of get all of your other stimuli out of the way, and so you can focus on that heart rate. It also helps to tap it out sometimes. I told you to calculate for a full minute, but a really quick way to double check yourself is to count for 6 seconds and multiply that by 10, and then compare that to your full minute count that you got, and they should be very, very close to each other. On the abdomen, you're going to listen to 4 quadrants. The baby should not have any masses or tenderness on palpation. So soft and rounded is normal. You're going to inspect the umbilical cord. So it should be clamped and drying with no drainage or redness. Initially, you'll be able to see those 3 vessels on a fresh umbilical cord. So look for those. So again, remember, it's 2 arteries and 1 vein. So just remember the girl's name, Ava. AVA, artery, vein, artery. On your genitalia, I had already mentioned that, so I'm not going to cover that again. Extremities and back I talked about. I also talked about the neurostatus and the reflexes. Next, I will talk about common newborn problems, and I will discuss each of these separately in the following 3 slides. So birth injuries are common. Okay, so here's a picture of a baby with a subconjunctival hemorrhage, so that little red area in the baby's eye. That is common. It will heal itself on its own. And then the other picture shows a baby with bruising. So if you can look at that baby has bruising all over its face. A baby that has a lot of bruising is at an increased risk of jaundice. So as those red blood cells break down, it causes increased bilirubin, and that baby's level can be higher. So typically we check a baby's bilirubin level at 24 hours of age. If that baby has a lot of bruising, we may need to check sooner. Their baby may also have lacerations. Every once in a while, the baby accidentally gets a laceration as they are being born. Other birth injuries I had mentioned, a clavicle fracture is your most common bone that can break. And usually that's going to happen in your larger babies. Jaundice is common in the newborn. Physiologic jaundice is harmless, and babies are expected to have some degree of jaundice because their livers are immature and they have all of this circulating red blood cells that they don't need. So they have a lot more circulating blood cells as a fetus than they need as a newborn. Those break down and cause jaundice. So treatment for jaundice, we want to encourage feedings because the bilirubin is then able to be excreted through stool. And so once the baby starts stooling, it helps bring that bilirubin level down. Pathologic jaundice, on the other hand, is a condition where something else has caused the baby to have jaundice that is not just that normal physiologic process that we expect to occur. So pathologic jaundice happens sooner, so starts in that first 24 hours. So again, think about that baby with all the bruising that has all that extra hemolysis happening. So that can lead to increased jaundice. If there's any incompatibilities in blood type from mom and baby. So what we're worried about there is one called ABO incompatibility. So if the mom's blood type is O and the baby's blood type is anything other than O, it is called ABO incompatibility, and it can lead to increased hemolysis. There's also RH isoimmunization. So if the mom is RH negative and the baby is RH positive, there can be some increased jaundice with that as well. Also polycythemia, so they have a really high red blood cell count. And this, risk factors for pathologic jaundice would be, again, significant bruising, babies that are preterm because their livers are even more immature and they're even more at risk of having feeding difficulties, and also your babies that are exclusively breastfeeding. So if you ever hear anybody use the term breast milk jaundice, that term is misleading. Just know it's not the breast milk that is causing the jaundice. It's the fact that the baby is not feeding enough and they're not able to then create enough urine and stools to be able to excrete the bilirubin. So babies that have signs and symptoms of jaundice, they're going to be poor feeders, they're going to be very lethargic. And if this jaundice is left untreated, it can lead to brain damage. The term for that is called kernicterus, Kernicterus. It is very, very rare in this country because we have methods to screen bilirubin levels, and we also have methods to treat it. So the treatment for it in the hospital, the baby will be put under a BiliLite, which helps that bilirubin bind and conjugate so that it can then be excreted. So that's going to be those babies under, it looks like a blue light in the nursery. They are uncovered. They're wearing just a diaper and some goggles to cover their eyes. But other than that, they have maximum skin exposure, and then they allow that light to work and kind of break down that bilirubin so it can be excreted. If jaundice is mild, the baby can be put in front of a sunlit window at home, and also encourage feedings so that baby can get that bilirubin out of its system. If the baby is exclusively breastfeeding and the mom is not getting enough milk, that may be one of those rare instances where you do have to supplement with formula. Hypoglycemia is a condition that is very common in newborns. So there are three main reasons why a baby will have hypoglycemia: decreased glycogen stores, increased metabolic needs, and hyperinsulinemia. So let's start with decreased glycogen stores. So that means that those babies have decreased stores of glycogen to begin with. So that's going to be like your preterm babies, your babies that are SGA. They just don't have a lot of reserve of glycogen to begin with. Next, we have increased metabolic needs. So think about those babies that are cold stressed, those babies that have respiratory distress and they're working harder. They're having demands to where they're having to utilize what glucose they do have. And then hyperinsulinemia, I had mentioned previously, that's going to be those babies, those infants of diabetic mothers who are getting all of that glucose from mom, and they are making their own insulin in response to that. Their glucose is removed, they're still making too much insulin, and they bottom out their own blood sugar level. So for hypoglycemia, most infants are asymptomatic, but they do, some signs and symptoms can be jitteriness, high-pitched and weak cry, cyanosis, apnea, hypothermia, and poor feedings. So treatment, you want to give a glucose source. There's a glucose gel that babies can be given. They just kind of rub it on the inside of their cheek. There's a protocol about how much glucose to give the baby based on their gestation, based on their weight, and also to promote feedings. So there is a nice little algorithm that is on the newborn floor in the nursery, and they will check the baby's AccuCheck level, and then they will determine treatment based on what that AccuCheck result is, and then whether the baby is showing symptoms. Here's a copy of the newborn hypoglycemia protocol that is in the nursery. This is an OSF protocol, and as you can see, based on what the AccuCheck reading is, determines how they're going to manage this baby. So there's not a real clear defined range for what is considered hypoglycemia in the newborn. Some sources go with 40, some go with 50, and their protocol varies based on what the result is as far as how you treat it. And at the bottom, it shows the glucose gel protocol and how much glucose gel you give based on the baby's weight. There are a few different screenings that are done on every newborn that comes through the newborn nursery. The first picture that shows those circles of blood from the baby's heel, that is the universal newborn screen. So what that is they are looking for different genetic disorders in a newborn. So it can test for up to about 60 different genetic disorders. So blood is collected on this card that all the circles are filled in and saturated, and then the results the paper gets sent off to a state laboratory, and if anything is abnormal with those results, they notify the baby's pediatrician because it takes a week or two for those results to come back. So some of the tests that the newborn screen looks for are congenital hypothyroidism, galactosemia, which is where a baby cannot tolerate breast milk or regular formula, so they may require soy milk, sickle cell, and also PKU, which is phenylketonuria, and that disorder, they lack an enzyme to metabolize phenylalanine, so they'll need a special formula for that. You may hear the newborn screen referred to as the PKU screen. PKU is just one of the disorders that is tested in the screen, but it was the first one that was screened for in the screening, which is why some people call it PKU. Next is a picture of a hearing screen. So every baby has a hearing screen done. The type of screening that they do here at the hospital is the automated auditory brain response. So what they do is they place these little electrodes, see that little white electrode that's on the baby's forehead. So they place one on the baby's forehead, one on the nape of their neck, and one on their shoulder. And they place those little earmuffs over the baby and hook them up to the machine that gives these little clicks or tapping noises. And what they're looking for is neural activity from the brainstem in response to those tapping noises. So every once in a while, a baby will refer on the hearing screen. A lot of times it's because the baby might still have some fluid in their ear. If they refer, meaning they don't pass their hearing screen after 2 attempts, the baby is referred to an audiologist and checked for congenital hearing loss, which is actually a pretty common congenital problem. About 10% of the babies who don't pass their hearing screens actually do have congenital hearing loss. And then the last picture that's shown is the baby with a pulse ox on. So that is the congenital heart disease screening. So with that, they are putting a pulse ox on the baby's right hand, which is considered preductal, okay? So before the blood gets to the ductus arteriosus in circulation, they're looking at the saturation rate from the preductal to the postductal reading, which is on either one of the baby's feet. So we want to wait until 24 hours of age to do this test to allow time for those fetal shunts to close. If a baby had a congenital heart defect that was dependent on those fetal shunts being open to be able to perfuse the body, you would see a difference in the pulse ox readings. They would not be able to perfuse their lower part of their body with certain congenital heart defects that didn't allow the blood to circulate properly. So if the baby has a difference in the pulse ox reading of more than 3%, that baby is considered not to pass that screening, and then they would then get an echocardiogram ordered to see if they truly did have a congenital heart defect. So in addition to these screening tests, at 24 hours of age, they also have a bilirubin level done, and that is done by a transcutaneous device. So they put it on the baby's chest and push a button. They do that 3 or 4 times, and it averages a reading of those results, and you get that level that way. If that is then high, then you would go on to get a serum bilirubin level on a baby. There's a different Billy tool that they look at to see what they want the baby's bilirubin level to be below. It's based on how many hours old the baby is and the baby's gestational age. So as kind of a rule of thumb, what I want you to remember is that a full-term baby at 24 hours of age, we want that bilirubin level to be under about 10. For your newborn care, some bathing and hygiene tips, see your textbook on page 595. You are always going to wear gloves if you are assessing a baby who has not yet had their bath. When you are doing giving a baby's bath, you're going to use plain water on the face and eyes and a mild soap for the rest of the body. Always put the baby under a radiant warmer when you're doing their bath. check their temperature before you do their bath because they are going to lose a little bit of heat as you're doing their bath. So you want to make sure they're warm enough to start with. So I would hold off doing a bath unless the baby's temperature were 98 or above axillary. Umbilical cord care, really there's nothing special. So back in the day, they used to tell parents to put alcohol in the cord to dry it out. Now that is no longer the recommendation. So leave the cord alone. Don't put the baby in a tub bath until that cord falls off. And make sure that the diaper is below the umbilical cord. So it will dry up and fall off in about a week and a half of age. For elimination and diaper area care, we did already talk about a little bit about urine and stool. Urine sometimes can be, it can vary between being very pale in color to kind of a darker amberish color. It may have what's called urates in it, so that is a normal finding. I already mentioned the stool pattern, and then diaper area care, just clean with wipes, and always remember to go front to back on your baby girl care. Circumcisions are done typically in the newborn period by the obstetrician. So there are a couple of different techniques of circumcision. One of them is called the Plastibell, where they actually put a little plastic ring around the foreskin. They trim the foreskin off, and they have a string tied around it with that little plastic part, and then whatever little bit of foreskin is left falls off with that plastic ring. And that comes off around the same time as the umbilical cord, so about a week and a half of age. The other technique is called a Gomco. And with a Gomco, it's a little device where they are trimming off all of the foreskin. So it's a little silver device. They put it on the base of the penis. They bring the foreskin up around it. They put this clamp on it, and basically they are cutting off the blood flow to that foreskin, and then they use a scalpel and they cut all of that foreskin off, and it makes a nice clean line. As far as what technique a physician uses, really it's just their preference. There may be a slightly higher risk of bleeding with the Gomco, but again, with that technique, you don't have to wait for anything to fall off. So it really is just a physician preference. That's after the circumcision, that base of the penis really does look pretty raw at first. You're going to be doing frequent checks for bleeding after they've had their circumcision, about every half hour for the first couple hours. You're going to pull back the diaper and check to make sure there isn't excessive bleeding. And then they do wrap it with a Vaseline gauze or petroleum jelly if they've had the Gomco done. And the Plastibell just is a little plastic ring that stays in place. As far as safety, review safety tips on page 589. Some considerations: the baby is always going to travel in the bassinet in the hallway. Students can bring baby to the nursery in their bassinet, but they cannot bring baby from the nursery to mom's room. The reason for that is there was an issue a while back with somebody not doing the band check between the mom and the baby. So what the band check is there's a little 5-digit number on the side of the name band that matches mom and baby have the same number. And so every time the baby gets brought to the mom, somebody needs to do that 5-digit check with the mom. Also on the unit, all of the doors are locked. Your badges work up on the unit for every door except for the newborn nursery door. Visitors all have a visitor badge, so make sure that everybody you see is wearing one of their visitor badges. Question anybody that doesn't have a badge because they shouldn't be up there. Babies have that little purple round sensor that's attached to their umbilical cord clamp so that they cannot be brought too closely to a stairwell or an elevator or an alarm will sound and security will come up. So make sure that if you are transporting a baby in the hallway, that you are not going too close to an elevator. There are signs posted that say no babies beyond this point, so you cannot go beyond that point with the baby. As far as infection prevention, you all know standard infection precautions. Always wash your hands, always Purell in and out of the rooms. Even the newborn nursery is considered walking into a patient room, so make sure you're Purell in and out of that room. As far as car seat safety, babies should have a 5-point harness. The straps should be tight enough so that you cannot pinch the straps and have them touching. The top straps should be at the level of the baby's shoulders or below their shoulders, and they should be rear facing until age 2. So the law recently changed that they need to be rear facing in their car seat until age 2. Sleep promotion, so babies sleep a lot, up to 15 hours a day at first, 2 to 4 hours at a time. They need to be sleeping on their back, no stuffed animals or soft fluffy blankets, crib bumpers, nothing in their crib. So it should just be baby and a light blanket. It is encouraged for babies to sleep in the same room as their parents, but not to co-sleep in the bed. So always educate your parents about the risks of co-sleeping with their baby. Let's see, bonding, we're promoting skin to skin. We're encouraging parents to be hands-on with cares, doing a lot of teaching for new parents up on the unit. Suggest ways that they can soothe the baby. So some new parents get very, very frustrated with a crying baby, especially if they have just been through a long labor and are very sleep deprived. So you can educate them about ways to soothe the baby. So swaddling a baby, rocking, holding, talking to the baby are all ways. As far as pacifiers are not routinely given out on the unit. And the reason for that is that studies have found that if pacifiers are introduced too early to a baby who is breastfeeding, it can interfere with how well the baby breastfeeds and how long that baby breastfeeds for. So the nursery does not automatically stock pacifiers and provide them for parents, but if they want to bring their own in, then they are welcome to do that. Follow-up care, always make sure that the parents have made a follow-up appointment with the pediatrician so that their baby receives proper follow-up.